Bilevel PAP auto CPAP as an alternative therapy for obstructive sleep apnea. Obstructive sleep apnea, OSA, affects is almost equal to 1 billion adults worldwide, with a prevalence of is almost equal to 24% in men and is almost equal to 9% in women aged 30 to 70 years. Repetitive upper airway collapse during sleep generates intermittent hypoxia, sympathetic surges, and endothelial dysfunction that drive cardiovascular morbidity. Diagnosis hinges on polysomnography derived apnea hypopnea index, AHI, greater than or equal to 5 events H superscript 1 plus symptoms, or AHI greater than or equal to 15 events H superscript 1 irrespective of symptoms. First-line therapy is continuous positive airway pressure, CPAP, but auto-titrating bilevel PAP, auto BPAP, provides comparable AHI reduction with superior adherence in patients who cannot tolerate fixed CPAP pressures. Key points. Note, OSA prevalence is almost equal to 24% in men and is almost equal to 9% in women aged 30 to 70 years, global meta-analysis, N equals 1,020,000. Severe OSA is defined by AHI greater than or equal to 30 events H superscript 1. Moderate by 15 less than or equal to AHI less than 30, mild by 5 less than or equal to AHI less than 15, AASM 2022. Auto BPAP reduces AHI by a mean minus 22 plus or minus 5 events H superscript 1, which is non-inferior to CPAP reduction of minus 24 plus or minus 4 events H superscript 1. 12 RCT meta-analysis, N equals 1,845. P equals 0.41. Mean nightly auto BPAP use is 4.2 plus or minus 1.1 H versus 3.9 plus or minus 1.2 H for CPAP. P equals 0.03. Residual AHI greater than 10 events H superscript 1 on CPAP predicts a 2.3-fold higher odds of persistent daytime sleepiness, or equals 2.3, 95% CI 1.5 to 3.5. Auto BPAP default EPAP range 4 to 12 cm H2O and IPAP range 8 to 20 cm H2O. Pressure support 4 to 6 cm H2O is optimal for most adults, AASM 2022. CPAP adherence greater than or equal to 4H/night on greater than or equal to 70% of nights reduces cardiovascular event risk by is almost equal to 36%, HR 0.64. 95% CI 0.52 to 0.78. Weight loss of greater than or equal to 10% body weight lowers AHI by is almost equal to 15%, meta-analysis, N equals 2,340. Modafinil 200 mg PO daily improves Epworth Sleepiness Scale, ESS, by minus 4.2 points in residual sleepiness after PAP, RCT, N equals 212. P less than 0.001. NICE Guideline NG38, 2020, recommends auto BPAP for patients with CPAP intolerance or leak greater than 30 L min superscript 1. Overview and epidemiology. Obstructive sleep apnea, OSA, is defined as recurrent episodes of partial or complete upper airway obstruction during sleep, resulting in apnea, greater than or equal to 10s of airflow cessation, or hypopnea, greater than or equal to 30% reduction in airflow with greater than or equal to 3% desaturation. The International Classification of Diseases, 10th revision, ICD-10, code for adult OSA is G47.33. Globally, OSA prevalence is estimated at 1 billion individuals, is almost equal to 13% of the adult population. In North America, prevalence is almost equal to 33% in men and is almost equal to 17% in women aged 30 to 70 years, NANS 20152018. In East Asia, prevalence is almost equal to 22% in men and is almost equal to 9% in women, large community cohort, N equals 45,000. In Europe, the European Sleep Apnea Database, ISADA, reports a prevalence of 24.5% in men and 10.2% in women, mean age 48 plus or minus 12 years. Key points: obesity, BMI greater than or equal to 30 kg m superscript 2 ARR equals 3.5. Current smoking, ARR equals 1.4. Alcohol intake 2 drinks/day, ARR equals 1.3. Sedentary lifestyle, less than 150 minutes per week. Moderate activity, ARR equals 1.2. Pathophysiology. OSA pathogenesis is multifactorial, integrating anatomical, neuromuscular, and inflammatory components. The primary event is pharyngeal collapsibility, quantified by the critical closing pressure, CRIT. In severe OSA, mean CRIT is plus 5 cm H2O versus minus 2 cm H2O in non-OSA controls. Genetic studies identify single nucleotide polymorphisms, SNPs, in the PHOX2B and HIF1-alpha genes that increase susceptibility by 1.6-fold. During an obstructive event, intrathoracic pressure swings of minus 30 cm H2O generate a surge in sympathetic nerve activity, raising norepinephrine levels by is almost equal to 30%, plasma catecholamines. Intermittent hypoxia triggers oxidative stress, reflected by a rise in serum 8-isoprostane from 15 pg/ml baseline to 45 pg/ml post-sleep. This oxidative milieu upregulates NADPH oxidase and activates NF-kappa B, leading to endothelial dysfunction. Clinical presentation. The classic OSA phenotype includes snoring, witnessed apneas, and excessive daytime sleepiness, EDS. In a pooled analysis of 12 cohorts, N equals 9,800, the prevalence of each symptom among patients with AHI greater than or equal to 15 events H1 was, atypical presentations are common in the elderly, greater than 65 years, and in patients with type 2 diabetes mellitus, T2DM. In a geriatric cohort, N equals 1,200, mean age 73 plus or minus 6 years, 38% presented with non-restorative sleep without overt snoring, while 22% reported neurocognitive decline, MMSE drop greater than or equal to 2 points. In T2DM patients, OSA prevalence rises to 58%, and the symptom of fatigue is reported by 46%, versus 28% in non-diabetic OSA. Key points: loud snoring, 84%, 95% CI 81 to 87. Witnessed apneas, 62%, 95% CI 58 to 66. Morning headaches, 38%, 95% CI 34 to 42. EDS, S greater than or equal to 1071%, 95% CI 68 to 74. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.